Hello, I'm Kharrazi, and today I will be talking about population health informatics, what it is, how we do it, and why we do it. I'm affiliated with the Johns Hopkins School of Public Health and also School of Medicine, and my research is mainly focused on population and public health informatics, risk stratification in population health, social determinants of health, and health equity. And today, my focus would be mainly on population health informatics. I'm the co-director of the Johns Hopkins Center for Population Health IT. I also co-direct the research and development of the Johns Hopkins ACG tool. And I'm also the associate editor for JMIA Open and Medical Care. In terms of teaching, I direct 2 doctoral programs, and I'm also the co-PI of our NLM training grant. So what is population health management and why do we do it? If you remember, almost a decade ago, the Institute for Healthcare Improvement came up with triple aims, where we try to lower the costs of our healthcare system while trying to improve the health of our individuals. Now, at the same time, the aim is that we should also improve the health of our population. However, there was always this big question mark: how can we improve the health of the overall population while we are trying to lower our costs and improve individual care? And that's what our focus has been. So we published a chapter in this book called The Public Health Informatics and Information Systems to explain a bit more on what is population health and how informatics play a big role in it. Now, this is sort of right now an empty framework on how population health works. You can see that there are different boxes, each of them labeled with a different topic here, but they're interconnected. So you can see on the left side, we have health determinants, and then on the right side, we have health outcomes. They're both highlighted by that purple box. Now, in terms of health determinants, you can see that we have different levels of health determinants that can help us to better understand what happens to different subpopulations. You can see it goes from gene level information to clinical, behavioral, social, and environmental. And all of them with this big arrow are connected to the health outcomes on the right side, where we can sort of predict what happens to the mortality, morbidity, quality of life, and wellness, and cost and utilization of a population. And of course, when we do this, we have to look at the angle of disparities and health equity as well. Now, to do this prediction, that's where population health analytics comes into place, where we do risk stratification, we do case finding, we do payment adjustment based on our scores, and that helps us to better predict our health outcomes. Now, you may wonder, how do we know about the health determinants? There are different data sources. And of course, EHRs and claims data is just one layer of the data. We have behavioral surveys, we have larger census data and other data sources about the built environment that can help us to understand those health determinants and hopefully to use them to better analyze the data and better predict the outcome of interest. There are multiple intervention types you can see up on the screen that can help us to better target the different subpopulations that can benefit from them, and hopefully we can improve the health outcomes. And then in the midst of all of this, there are different stakeholders that are involved: patients, providers, payers, and so on. Now, I'll highlight here the areas that it's of course, our interest here at Hopkins in my center. But of course, sort of population health analysts can look at any of these sort of boxes. So you can see the stacks of layers of health determinants that we focus on, the type of health outcomes that we focus, which is cost and utilization, and disparities in those outcomes. And in terms of analytics, is the risk stratification case finding, specifically for interventions designed for a health system, and the stakeholders that are usually involved in such interventions, which are providers, payers, and sometimes public health departments. Now, this was the entire framework of how population health works. We hope that we can improve the health of the population this way. Now, you may wonder that analytics, how does it work? So when we bring in the data, so you had these boxes of the determinants on the left and the outcomes on the right. So determinants on the left will feed into some analytic platforms where we try to slice and dice the population in a way to find out who is high risk and who is at a lower risk of certain outcomes. So as you can see in this pyramid, most of the population are folks that would never come to your health system. They just came, maybe last year and they're healthy otherwise. Maybe they only come for checkups on an annual basis. Then we have some users that they come for minor issues, but more frequently. Then we have patients that have single high impact disease, like let's say they have diabetes, they have asthma, they come for regular checkups on their chronic conditions. And then, of course, we have patients on the top of the pyramid, which we call them high disease burden patients, where they have complex comorbidities and they need more attention. And depending on where these patients fall, we have different interventions for them. So you can see the more costly or time-consuming interventions, like a case management, is usually aligned with the high disease burden population. And then other types of interventions that are usually sort of more affordable, doesn't need much resources, are aligned with other segments of that risk population. So again, the aim is usually in population health analytics to find the top of the pyramid who falls there. So hopefully we can manage them better and reduce not only their costs, but also improve their health outcomes. Now, in terms of data sources, people ask me, what do you use? And frankly, as you saw, that there are different stacks of health determinants. So we look at a lot of different data sources. So if the patient and physician interact, maybe a fraction of days throughout the year, but they also interact with their own networks for most of the year. So you can see patients on the right side, they interact with their family, physicians on the left side with their practice teams, and so on, the bigger sort of circles on each side. Now, there are a lot of different data sources that you can use from each side. So on the health system side, on the left side, you can see the electronic health records, EHRs. You can use insurance claims data, health information exchange data, and so on. And on the right side, of course, patients also generate a lot of data that you can capture from them, going from mobile health apps to social networks and so on. And all of this, plus some data sources that are sort of communicating between the two, that is the ideal way to look at population health. So in an ideal world, if we have all of this data, then this could help us to understand what is happening to a given population, being able to better risk stratify them and direct our usually scarce resources that we have to the patients that are at the top of that pyramid. They need those resources the most. So there's another way to look at this. So if you look at all of the different sectors, up there you can see the private sector, patients, providers, payers, and so on. They all generate their own data sets. So either it's behavior, clinical, social, or environmental. You can see the span of different data that's generated from each of these sort of slices of stakeholders in our healthcare system. And I just want to say that this is a busy slide here. What I'm trying to say here is that something like, for example, electronic health record that we often use it for a lot of our analytics is only a small piece of this big puzzle. So in population health, we often are trying to see if we can bring more pieces of the puzzle to find a better picture, to draw a better picture of what is actually happening to that population. So over the years in our center at Hopkins, we have developed a tool that does the slicing and dicing, generates a lot of different risk scores. It's called the Johns Hopkins ACG tool. these days up to, this is now close to 3,000 peer-reviewed articles have used the ACG tools in order to slice and dice the population, calculate their comorbidity levels, and then use those either to predict something or control for some underlying conditions to better do the studies that they're doing. So this tool, ACG tool, has been traditionally using claims data in an sort of a payer environment where insurance companies will try to find out what happens to different segments of the population in terms of their costs and health outcomes, so then they can address those issues earlier than later. But then, of course, ACG now is being used in a lot of different settings, even in clinical settings that sometimes people are using it for clinical decision support. We call that variation of ACG the EACG or EHR-based ACG, where we have brought in other things from the EHR that we couldn't find in claims, like lab results, vital signs, and other factors in the EHR. And here's just a diagram that shows how ACG in general works. So you can see demographic data, medication data, and pharmacy data feeds into the model, and then it generates a lot of different markers and risk scores that are usually used for risk prediction. Often different population health management offices, they use these scores to rank the patients on on different scores, and then they target their interventions for people that fall within a certain percentile of that risk score. So that was population health, what we do. And most of our healthcare providers here in the US now have a population health office that are trying to manage the sort of both costs and outcomes of that population at the same time as the health system is trying to sort of evolve. And that is population health management. I need to stress it's a essential part of a learning health system, because it's probably the shortest way to manage how we learn from our population and how we affect large segments of our population with different population level interventions. Now, informatics play a big role here. So this is population health informatics. We defined it in a paper that we published almost like 7-8 years ago. And we tried to sort of make a distinction between population health management and public health, population health informatics and public health informatics. So this is a famous diagram from Dr. Shortlift's book, where different domains of informatics are drawn. You can see the domains here in the middle of the screen: bioinformatics, imaging informatics, clinical informatics, and so on. And they all have different ranges of being, basic research or applied research. That's the vertical axis, and you can see the horizontal axis going from more of a molecular research to a community research. And we define population health informatics something that sort of merges the last three into one bucket. And then, of course, the target group is what I discussed in the population health management discussion, where we hope that we can improve the outcomes of large populations. We can predict those outcomes and then hopefully intervene as needed. Here you can see another diagram that we used in that paper to try to say how population health informatics is a bit different than public health informatics. Those circles are similar to the circles that I showed earlier when I was discussing the data sources. You can see patient and clinician sort of interacting, and each of them have their own circles on the left and right side. And you can see public health informatics at the bottom. It has at the bottom right, it shows that focus is usually on total population. They're usually on government created geo-boundaries. Public health departments are usually based on a county or a state. But population health informatics is a bit different. It actually gets into both sides, and both the clinical side and the patient side. It's usually patient level data that we use, and it's often not bound to a state or a county. It could be any health system or a payer with large patient populations, and that's where informatics will help us to better manage that population. So here's a diagram starting from the upper left. We put together all of the data for population health analytics. That alone takes a lot of time. As I showed, we bring in data that it's beyond just EHRs and claims. Then we have to check the quality of the data and so-called clean it. That takes often half of our time. And then when you move to the right, you can see that we develop a lot of models to predict what happens to different subpopulations. So that's where it becomes very much a lot of statistical sciences and machine learning and AI will go into that. Then another big step is when we come down now in this diagram, you can see that we need to generalize these models. The problem is a lot of models we develop, for example, for the Johns Hopkins ACG tool, are widely used here in the US, and almost 20 different governments internationally use it. So we have to make sure that our models not only work with the data that we work with, but also work elsewhere. So that needs a lot of making sure that it's trained enough, but it's not overtrained. And that way the model could be generalized. And then, of course, we hope that this knowledge could be shared with others, these models, and then the models that have been now in place in different settings will generate new ways that we are managing population. That creates new data, and then the new data could be sent to us so we can retrain the model. This would be a way that the models changing the population health management approaches, and then that generates new data, and then the data will feed back. So we hope that this will be a good circle of data analysis, and then impact, and then new data. However, it's not always, new data coming back to us that easily. So this sort of a cycle here is not always complete. It usually gets to the generalization, and we stop sort of there, and we hope that we will do a better job in bringing everything back. Now, you may ask, well, this is all analytics, where's informatics? So informatics is basically addressing different parts of these buckets that I mentioned. So for the example, in the first bucket, there is a lot of data harmonization needed. The second bucket is data quality. You can see another bucket that's all about knowledge generation. Then we have knowledge generalization, sharing, and knowledge management. So informaticians always work on these areas, but I wanted just to show that when it's contextualized to what we do in population health analytics, how each of these different sort of domains of informatics could be of interest to these sort of analysts that are trying to better predict what happens to different segments of the population. Now, this is another way to look at it. So if population health analytics is the core here, you can see informatics around it. And when we bring in all of these data sources, claims, EHR, hospital discharge record surveys, social determinants of health, all of that data, then we need to do the harmonization, data quality checks, and sometimes data extraction also to better find out the markers, the predictors that can help us to better predict the outcomes that we wanted. And then, of course, when we do these predictions, how we can make sure that our models are generalizable and they don't have bias or equity issues in them. So that way, then we can affect all of these different outcomes. So today, I picked a couple of the sample projects we did, for example, on data quality, some on data extraction, a bit on data harmonization as well. So you can see the effect of informatics. Of course, in our center, we do a lot of different projects that relates on how informatics can help with population health analytics, but and I'm more than happy to share those as needed. So let's look at some of the PHI projects. So these are population health informatics projects on how we that show how we bring in informatics to improve population health processes. We'll look at two projects on data quality measurement and knowing what data we are working with, what population you're working at before you even start the population health analytics process. We'll look at data source value assessment. Is claims data better or EHR data better for population health risk stratification? So this is a big question that has been always out there for insurers and providers. I'll talk about that. Specifically for the audience of this presentation, we create a lot of new markers and concepts on how to predict certain outcomes, population level outcomes. And a marker that has been always in discussion is frailty and the geriatric syndrome, and how we can use that to better predict the outcomes, namely healthcare utilization in a given population. And you can see here, we had two studies there, comparing again EHR and claims, whether frailty extracted from claims is as good as EHR or vice versa. And then another one, can we extract frailty from, let's say, EHR's free text? Is that possible? And then there are a lot of other sample projects that I wished if I had the time to go through them, but are not discussed today. We do a lot of work in improving models, so a lot of AI and machine learning to be able to have better methods that we can use to do a better prediction. We also do a lot of disparities analysis, and we want to make sure that our models are not biased based on different racial categories or gender categories. So that's another area that is not discussed in this presentation, but I'm more than happy to share those as needed. So let's look at data quality issues. So I look at these studies as we haven't even started the population health analytics, and we are looking at the denominator of patients that we are selecting and making sure that the data quality is good enough that then we can do our analysis on it. The problem is that in the real world setting, a lot of times a database person just cuts the data, has some inclusion exclusion criteria, and then a statistician usually gets the data and mines it. And nobody knows, what happened to the data quality. The most that happens out there is that statisticians may deal with data completeness to some extent, but other areas of data quality is usually not addressed well. So we have data accuracy or correctness, we have timeliness or currency, we have a plausibility, provenance. We have so many different layers of data quality that we discuss in informatics, but we don't have them in operations. So we wanted just to see how data quality works for a common data that we use out there. There is a data set called HCUP, or Healthcare Utilization Project by AHRQ. So the federal government goes to many states, almost 40 states, and they collect all of the hospital discharge records on an annual basis from hospitals, ERs, and outpatient facilities within hospitals. And then they sort of harmonize it and curate it and put it all in one place that you can go and actually purchase to do your research. This is highly curated, but we found that even in a highly curated data set, we have a lot of issues with even mundane data types such as demographics. So the aim of the study was to measure the quality of demographic data in Maryland's hospital discharge data, spanning across 8 years, so around 50 million records encounters in inpatient, ED, and outpatient settings of hospitals. You can see we didn't have any inclusion exclusion criteria because we are just measuring data quality at this stage. So we included everybody just to see whether demographic data such as age, sex, marital status, and so on are collected completely and accurately and on a timely basis or not. So the data quality measures that we looked at is completeness, whether it's missing or not, correctness, whether it's accurate or not. Like, we can't have somebody whose age is less than 0 or more than 120, because we know based on the Guinness Book of Records, we don't have anybody who's more than 120 years old. And then consistency, whether somebody's, let's say, biological sex or race has been the same across different visits, or when they went to different hospital settings. Is it the same or it's changing? So if it's changing, why is that? Is that a mistake or there was some other reason for that? So I just jumped to some of the results quickly here. So you can see on the left side, that's the completeness track. We were looking whether data is complete or not. And we started with 7.3 million patients across all of those years, almost 50 million encounters. And you can see after we prune the patients based on, sex, age, race, marital status, their zip code of residence. This is a zip 3-digit, the first 3 digits of the zip code. And whether they died or not, we found out that only 6.7 million of those patients are left in the database. So just a simple completeness check drops that many patients. And then we looked at the correctness issues. You can see more patients are dropped. Now we are 6.76. And then when we look at the consistency across different settings, whether the patient keeps the same race or not, and things like that, whether their marital status, makes sense logically or not, we end up with 6.6 million patients. So you can see we go from 7.3 to 6.6. And it is very unfortunate that such a data quality check is not done for most of the research that uses this data source. I would say almost 500 papers are published using age-cup data almost every year. I've rarely seen them looking at all of these dimensions of data quality. Here's just another representation on how this looks like. So remember, they were going from 7.3 million to 6.6 million. So the ones that had data quality issues are shown here, and you can see race has the biggest circle and marital status is next, and then other circles. So it is good to know where are the issues. So for example, if you want to do a racial disparities analysis using age-cup data, you have to be aware that almost in Maryland in those years, 460-some thousand patients had racial data quality issues. So being aware of this then will help us to better understand what those results mean. Here's just the population. So this was a very long table. We broke it into 2 pieces, left and right. And you can see on the left side, for example, you have the original population, which was 7.3 million. We dropped almost 700,000, and then the remaining population. So these are the 3 columns. The dropped column, the middle one, is the ones that had data quality issues. And you can see when you compare that population to the remaining population or the original population, there might be some meaningful differences that you need to be aware of. For example, they seem to be slightly older, the population that had data quality issue. They tended to be, having less of a white population based on the racial categories that we had, and so on. I don't want to go through all of these rows and columns, but I've highlighted some examples in red where it would be interesting to know. For example, the income level based on the residential zip code, the population that we removed ended up actually being in the lower quarters of income. So the lower quartile income population seem to have less of a data quality for their demographic data. So this is important when you run the population health analytics on it, so we know what type of a population we are working with. Here's just 2 more tables about this population of the removed versus the remaining, and I've highlighted a couple other ones just to show that there are some differences. So for example, here on the left side, if you look at the removed population, which is the middle column, at the bottom is the comorbidity scores. And you can see something like a Charlson score, Elixhauser score, that are scores that show how sick or how sick a population is, how many comorbidities they have, and what is their chances for certain outcomes. You can see the Charlson score, for example, is considerably higher than the original population. It seems that the more, the sicker population had more of a data quality issue compared to the rest. So this is important when we do population health analytics. So we are aware of it before we go into it and try to cut the denominator out and do our modeling. Here's another study. This was funded by the FDA, looking at type 2 diabetic patients. The original study was on the problem of racial disparities in the presentation of adverse drug events in type 2 diabetic patients, where their blood glucose levels will drop too much, they'll end up going to the ED, and we wanted to see whether there are racial disparities there. And in the midst of it, we wanted just to see who are the diabetic patients and how we have to look at it. And then when we did the data quality, we found also issues there. This is the data quality aspect of that project. You can see we used the Johns Hopkins Medical Institute's EHR data, around 140,000 patients across 3 years. We included all patient records. Anybody who had something with diabetes, we included it. And then we ran a couple of phenotypes. Phenotypes are algorithms that can define who has diabetes, for example, who doesn't. You can see a bunch of them here, including one by Hopkins. Then we looked at data quality issues, whether the data, if the data is complete, correct, or current, would that change how these phenotypes will work? So we did a bit of a simulation. I'll show it to you. And then we looked at across different phenotypes, whether the population that we are identifying is different or not. Remember, the phenotypes are basically defining your denominator of your study, basically your study population. Most of the time we think, hey, it's very straightforward. We cut the data this way, and that's my study population. But we know in population health, depending on what phenotype you use and how data quality, how you're approaching data quality, you may end up having different populations at the end of the day. This specific outcome here that I showed, we are not discussing. That was the original study. I'm only discussing the data quality issues here. So here's an interesting, issue. So when we started this project, we thought, well, type 2 diabetes, it's probably easy. We have an algorithm that we go in our database and we select all of those patients, and it is not that easy. Apparently, there's not one universal definition for type 2 diabetes. So you can see here the phenotype algorithms. There are a bunch of them. And here on the screen, this Venn diagram, the gray shows what we cut out of the database. That's a raw data cut that included anybody who had anything with diabetes, any diagnostic codes, any medication, any lab results, anything that could be remotely, related. But then when we applied these algorithms, you can see that they each found a different segment of the population. And this is very important because, frankly, if I use any of these phenotypes, I may have different models at the end of the day that may behave differently in other settings. There might be even racial biases in how these sort of populations are being identified. So this is very important to know what phenotype you're using for what purpose. So, for example, here you can see the eMERGE phenotype, the one that has a bit of a green on top. It seemed to be the smallest one, but then something like the DDC or CCW, which is sort of red and yellow on the left and right, they seem to be the larger circles. Now, this is a very busy table. You don't need to read, all cells here, but basically all of the columns are the phenotypes that I showed you, and all of the rows are the specification of population that were identified by those phenotypes. So you can see, for example, here, the CCW phenotype, look at that column, has a mean age of 65 years old, while the other phenotypes have a lower age. Depending on your study, if you're very sensitive on age in your analysis, then, well, you have to be careful what of these phenotypes you're choosing. Let's say here, percentage of female population in each of the phenotypes. Some phenotypes had fewer females than males, and the other ones had it the other way around. So these could be important depending on, again, the research question you're asking, or the percentage of a specific racial group. That could be differently presented in different phenotypes. Here's the same table. It just couldn't fit all of the rows in the last one. Here's more. You can see Charlson comorbidity score, number of inpatient visits. Basically, this is more population health management sort of predictors and outcomes. Here you can see the CCW, which is heavily used by CMS to define, diabetic patients. has a mean comorbidity score of 6.18, which is higher than the other ones, given that that group also had a bit of a slightly higher age mean. This is understandable, of course. And then there are a couple other ones that I've sort of highlighted as interesting findings where it's the same diabetic patients. Most studies don't even care about saying how they ended up with the diabetic patients in front of them, but you can see here, depending on how you cut out the diabetic patients from your database, you may end up having, slightly different populations, which could be very important for your study. So what I wanted to also say is it is also very important to know what you feed into a phenotype. So the phenotype of a diabetes uses 3 types of data. So diagnosis codes for diabetes, that's a no-brainer. Then we have medications that are exclusively given to diabetic patients. So that's also something you can look for, either the prescription, the EHR, or the, whether the medication was filled on the claim side. And then we have the lab results, right? So hemoglobin A1Cs or blood sugar levels could be used to identify whether a patient has diabetes or not. So here in this Venn diagram, you can see the phenotype of DDC is using all 3. And you can see the diagnostic codes, found most of the population. And then we see the RX and LX. RX is the medications in blue, and LX is in green. It's the labs. They also found some additional people, in addition to what the diagnostic codes found. Now, the other phenotypes use the other 3 phenotypes I'm going to show you use also these 3 sources of data, but slightly different combinations. And this is important sometimes to know. So if you don't have, let's say, RX information, which of these phenotypes would be the best to find, the most diabetic patients in your data or not. I did not show CCW here because CCW only uses diagnostic codes, does not use medications or LX, so it'll be just one red circle. Now, we simulated data quality issues here. So here you can see as data quality, for example, completeness here. So the horizontal axis is the percentage of diagnostic codes that we are dropping from the EHR to simulate data completeness issues. And each of the lines that have different colors is a different phenotypes. As we go to the right, we are dropping more and more diagnostic codes, sort of making the EHR data messier and more incomplete. And then you can see how many patients are found by that phenotype compared to the initial state of the phenotype. So sort of that's the vertical axis. So as you can see, we move to the right, they drop, right? Because we're dropping diagnostic codes, but some of them drop way more than others, like CCW here drops entirely to 0. It cannot find any patient because we don't have any diagnostic codes anymore, and CCW is only based on diagnostic codes. But the other ones use also other things, right? Medications and lab results. So they are still finding some patients, even if you don't have diagnostic codes. So again, this is also important to know in terms of, the data quality of your health system. Do you get all of the feeds for medications or diagnostic codes from your HIE or the lab results? Do you get, feeds from Quest and LabCorp? Is it all in one place? Can that help you to use a phenotype that hopefully can sort of help you to find more diabetic patients in your data set, if that's of importance to you to run a clinical trial or do a retrospective data analysis for population health analytics. Remember that sort of diagram that I showed on the data quality? I'm actually showing the Venn diagram of each of these sections, cross sections of data quality. So on the left side, I'm just increasing the cuts, dropping more and more diagnostic codes. And you can see, for example, CCW is not present in the last cut of the data anymore because there's no more diagnostic codes left. But then there are some other phenotypes that are still picking up diabetic patients based on labs and medications. So just one more study, and that's measuring the value of EHR in predicting healthcare utilization. So we use EHR data of around 140,000 patients. They all had one EHR record and 6 months of insurance data. We use demographics, diagnostics, and medications to predict healthcare utilization. It was published in this paper, and we just need to know that claims and EHR data are inherently different from each other, especially, EHR data brings in data sources like family history, problem lists, procedures, and so on that we don't have in claims. I don't want to go through this entire table. You can study it later, but they're just different nature. And one problem with EHR is, it doesn't match completely with claims data. There's always some overlap, but there's always things happen to patient elsewhere, not in your health system, that it's captured in claims data, but doesn't show up in EHR data. So here's one diagram that shows all of the ICD codes of these 140,000 patients that we had both their EHR and claims data. And you can see the blue is what we found in claims data. The red is what we found in claims and EHR data, and the green is only in the EHR data. So this way you can see if you use the totality of EHR, which is the green and red, you're missing all of the blue. If you use the totality of claims, it's blue and red, but you're missing the green. So of course, if you have both data sources, is the best, but here we just show that, at least in terms of diagnostic codes, seems claims data has a lot of diagnostic codes for your patients that you may not know about in your own EHR. This was another study just to reflect on this. This was almost 60 different providers, all of their EHR and claims data. And you can see the blue here is the claims only, the EHR only is the red, and the overlap of what EHR and claims both had at the same time is the green. So if you choose the totality of claims, you get all of the green and the blue. If you use EHR, all of the data in EHR in terms of diagnostic codes, you get, the green and the red. So it seems that EHR is missing, a good amount of diagnostic codes, and it's understandable. I can call this EHR data leakage or diagnostic leakage, where, a patient goes elsewhere, not in my health system, sees a doctor in another health system. The diagnosis code is reported in the claims, but it stays in the EHR of that health system. It never comes to me unless if I'm interconnected, the HIE sort of is interoperable, and it's sending me the data from that EHR to my EHR, but that doesn't happen that often. So there is a lot of the diagnostic codes that are sitting elsewhere in other EHRs that never shows up in my EHR, but most of them will go into the claims database. And here in this study, for example, shows the rows are different, major chronic conditions like diabetes, hypertension, depression, and so on. And I want to only direct you to the overlap column here. So you can see in diabetes, the overlap of this code being found in both EHR and claims is 88%. If you look at the medication, it's 71%. So if you have diabetes, most probably it shows up, in the EHR of your health system, not only the claims data, but in depression was different. It's 54%. So the chances that, it's in the EHR on claims is lower. You can see the claims only and EHR only columns are, considerable. So in this case, if you only use EHR data, you would miss 27% of the diagnostic codes of depression in these 140,000 patients. Of course, depending on how many, how loyal your patients are to coming back to your health system, these percentages would be very different, right? So if you're a closed system where, let's say like Kaiser Permanente, where patients always go back to Kaiser almost all the time, then your EHR data is almost as close as claims data. But for a health system that, is open like Johns Hopkins, we will probably have a lot of missing diagnostic codes that, might be in the claims, but not in our EHR. And those affect how you predict. So here's predicting hospitalization, for example. And if you focus only on those highlighted box, you can see the accuracy of this model, this binary logistic model trying to predict that these are the AUCs, or the area under the curve. You can see when you use diagnostics and medication codes from claims for predicting hospitalization in the same year, that's the first row of the data, it's 0.87, it's pretty good. But then if you only use EHR data for the same patient population, but the DX and RX comes, the diagnostics and medication comes from EHR, it drops to 0.809. So EHR data could not do as well as the claims data, but it's still not that bad. Still, if that's the only source of data you have, then you may use EHR data. So EHR data, of course, we only compared the diagnostics and medications to claims data in those studies. We also did a couple, dozen other studies on seeing what else EHR data can give us. EHR data gives us signs and symptoms that sometimes don't show up in claims, lab values, vital signs, medication adherence measures, family history, immunization records, new markers altogether, and also social determinants of health. We did tons of studies on those ones that are not described here. Now, I want to just explain to you what is geriatric frailty in this context. This is a marker that we are growingly using in our analytics. I don't want to get into the concept of what is geriatric frailty, but it's there are different ways that it could be calculated. It's usually based on surveys, and it's not well coded, the different constructs that go into geriatric frailty. Hence, it's very hard to get it out from claims and EHR unless if it's collected at the point of care through those surveys. Now, what we did, there are like two studies here. One was to look at EHR's free text, the clinical notes that the physician types, to find out whether a patient has frailty or not. And we looked at 40,000 patients. We had their EHR claims, but on the EHR side, we also had their free text. We wanted to see whether we can find more patients with frailty constructs or dimensions using the free text. So, and hopefully, to be able to use those to better predict what happened to these patients. These are the papers that we published on that project. But here we have claims, EHRs, both structured, ICD, RX codes, and so on, but also the free text, the clinical notes that the physician has written. And then what we did is we tried to look at the different constructs of frailty. Here you can see I've mentioned a number of them, but you can see something, for example, dementia is well coded. The green shows what the EHR's free text adds to claims and the structured EHR, which are the red and the blue. So you can see the green adds a bit, but not much. But look at the bottom row. There are a lot of these constructs that are important for frailty, but they're not well coded. Lack of social support, for example, was not coded at all in the population, except only for a few patients. So you can see the green adds a lot to our ability to find patients that are prone to frailty. And of course, you can use that information to better do, your typical predictions for population health analytics. We brought those, markers into our models, and then we found that we can improve our model. Here, I just highlighted one section of this table that shows the odds ratio of being able to predict certain outcomes. And for nursing home admission, adding these markers was very helpful. We can increase the prediction of our traditional models much better than what we had before incorporating those indices. And this is the last one. So this was funded by AHRQ to find out whether using the structured data on trying to calculate or predict frailty in claims could be as good as using EHR data or the other way around. So we used Kim's model, which is an established model to calculate the amount of frailty. You can see we use different data sources here. We wanted to go to different health systems that have different overlap, different levels of overlap between EHR and claims data. You can see we used Hopkins data, Optum Labs data warehouse that has data from almost 60 different providers in it, and KP. We looked at all adult patients, and we wanted just to see how much of a concordance we have between EHR-based frailty index and claims-based frailty index. This is published in this report. You can follow the PDF, and all details are there. Just want to highlight some interesting findings here. I wanted just to first of all say that it's very important, again, to know how much EHR and claims are overlapping. just their structured data. And a provider A, an example, their EHR collects almost everything about the patients that shows up in claims data. These are usually the more closed systems where patients always go back to that healthcare provider. But as you go to the right, there are systems that are more tertiary care, more, specialty care. Patient comes only for a very specific thing. They don't get their primary care there. They go elsewhere. So a lot of the stuff that it's in their claims data usually don't show up in our EHR. So depending on where you are on the scale, when you want to calculate frailty, for example, on EHR versus claims, you may get different results. And this was the case in our study where KP is very much of a closed system. Hopkins is very much of an open system where, a lot of patients don't get their primary care from us. And then in Optum Labs data warehouse, we had 60 different health systems with different sort of overlap of these circles. And this is all in that report, and you can study it later, but the amount of frailty we found using both EHR and claims data was hovering around 7 to 8%. This is in the Optum Labs data warehouse, which is 60 providers. It's the largest one with millions of patients. And you can see here on the right side, the ratio here that we have. It's 2.8, 2.7, 2.8, and 2.6. That means in every given year of the data, claims data added more patients in finding frailty for them compared to EHR. So overall claims data was better in identifying those patients, but EHR data was also good enough. So this was sort of trying to see whether this model of frailty is good if you use only EHR data. This is the concordance. So whatever we found in EHR was very close to claims data, but it was always lower a bit. Here, this diagram basically shows it much better. These are 60 different providers, each of the on the horizontal axis. For each of them, the blue sort of point is showing the level of frailty found in the EHR, and the corresponding point in the orange line shows how many we found using claims data. So although we have connected these dots just for visualization purposes, these are dots basically for each of these providers, like S0048. It's a provider in that data warehouse. You can see that these dots always these two lines are following almost the same distance. So that means across 60 different providers, when you use EHR versus claims data, you sort of get the a concordance level of frailty identified in the population, although EHR is consistently lower than claims data. And this is important when you want to do predictions of healthcare utilization and population health. You can bring these measures in now, knowing that EHR data is at least consistent. It's lower, but it's at least consistent. You can calculate it based on your EHR data and put it in your model and hopefully do a better prediction, because when you do that, it helps you to do better predictions. So here, for example, we are predicting IP, which is inpatient hospitalization, ED, which is ED admissions or emergency department admission, and nursing home admissions, NH. And you can see that frailty index has a good odds ratio to help us to identify such patients. This was only the Hopkins data, and the report, it's the data from other places as well, and how that helped the prediction. But this is sort of the main result, where you can see inpatient hospitalization, ED admission, and nursing home admission represented by the blue, red, and green lines. And then EFI is the EHR-based frailty index, and CFI is the claims-based frailty index. And how much they improve the model, that's the odds ratio shown. Most health systems don't have both claims and EHR, so EFI is usually not feasible to have. But looking at EFI, for example, at Hopkins, that's the JHMI data, you can see that predicting any of these outcomes, IP, ED, or NH, has a good odds ratio, 3.47, 6.57, and 7.61. And you can see this is Optum Labs data warehouse. So you can see that They also have good odds ratios, so that means incorporating frailty in such predictive models is a good thing. And this was KP. So these were the main findings, whether frailty found in EHR or claims could help us to do better predictions of these outcomes. And it turned out that it could. So these are some, just findings. I'll invite you to read the report to reflect on, the main findings we had and the conclusion we made, which was basically, yes, use EHR data to calculate frailty. Even the structured data is good enough. It's consistent. It doesn't identify enough patients, but it's good enough for your predictions if you want to incorporate them. Now, just 2 more slides on the challenges and opportunities that we have in PHI. We always have an issue on what data source brings what. Is it good enough? Does it have any value or not? I just showed you EHR versus claims. I can go on and on and on with a lot of other data sources, like, we are bringing in, we have done several studies looking at social determinants of health, for example. Can that help you or not? We have done data quality measurements, and I showed you 2 of those studies. Many studies we have done just to see what data quality is needed for what type of an outcome. And then we have done denominator selections. So now I showed that we should go beyond the claims data, like I've shown here, for example, and going beyond certain methods that we use. On an everyday basis, we use regression, but here are some of the new methods. We have done a lot of machine learning and temporal data analysis, geoanalysis to better predict what happens to different patient populations. And of course, what I mentioned in terms of the role of informatics and quality, hopefully improving interoperability to have more data in, let's say, EHRs, or using natural language processing to get more data out of the free text. And eventually, other things we can do. And the last item, which is the most important one for this presentation that I tried to explain, was how we can use new markers such as frailty to better predict what happens to these patients. Okay, thank you for listening to this lengthy presentation. I hope I was able to explain how population health works and why we do it, and how we bring in informatics to better improve our models and better predict what happens to different segments of our population. And in the context of all of this, I try to put a more emphasis on frailty, geriatric frailty, and how that could be used as a marker in predicting utilization. Thank you so much for your time. Here's my information. You can always reach me by email, and I'm happy to talk to you later. Thank you. Bye-bye.